All right. Well, what day is today? Thursday, everyone. Thanks for joining us today. It is our monthly AMCHP COVID Town Hall / policy update. And we have a very full schedule today. So we will try to ask all the presenters to keep their remarks within a reasonable time so that we can get through everyone and leave plenty of time for questions. As a reminder, everyone is able to unmute during Q&A. If you have any questions for presenters, we ask that when you type it in the chat box, you also click the all panelists and attendees so everyone can see your question. And Jess Cohen is available for any technical difficulties, jcohen@amchip.org. So I'll start with a very quick legislative update. We'll have some updates from MCHB, and we are joined by some colleagues from Massachusetts who will share about their COVID waiver experience. The CDC will share some updates as well. And then we are also really pleased to be joined by a young woman who's going to share youth perspective specifically on mental health and suicide risk and addressing the needs of youth with disabilities. So the big legislative update, obviously Congress is not in session this week and we're all watching the elections, I'm sure. I was joking with some of my colleagues earlier this morning that I am, like, for the past few days, very low on sleep, very high on Halloween candy. So apologies if I'm not as coherent as normally. But the reason I bring this up, obviously we're waiting for, the final tally on the Electoral College for the presidential. But we've been saying for a while that what happens next in terms of some of our priorities for legislation really depends on how the election goes in the House and Senate. So in the House, it looks like Democrats have retained the majority, have not increased it, which a lot of folks were predicting before. So that could narrow some paths forward in the House, but for the most part, that it remains status quo. In the Senate, however, Democrats have gained at least one seat, and they're still, as of this morning when I screenshotted this, but also right now, I just checked it again, 4 seats that haven't been called, 1, possibly 2, both in Georgia that could go to a runoff. So we won't really have final results until December. And then Alaska, North Carolina haven't been called yet. Probably safe to say Alaska is looking like it will be Republican, and North Carolina, not sure yet, but either way, it's going to be really close in the Senate. And we don't really know yet if there's going to be any change in the control of power there. So still watching that closely to see how that might impact, obviously, our next year and our agenda for the next Congress, but also in terms of what gets done just in the next 2 months during the lame duck period is really important as well. Before the election, there was a lot of frustration feeling like Senator McConnell wasn't really pushing through a large COVID relief package. And then he gave a press conference this week saying, okay, now that the elections are over, we need to do a COVID relief package. So maybe he has changed his mind on that. Negotiations will still, of course, have to continue with the House. We are still hopeful for a number of priorities that we have had, like the Medicaid postpartum extension, appropriations, at least a continuing resolution of which should happen by like December 11th-ish, if there's going to be some sort of package that moves forward. So we still have our eyes on all of that, but I don't really know yet if, the way the Senate has or hasn't changed control will impact that, and also where they'll land on negotiations on a COVID relief package, given the status of what may or may not be called on the presidential. So a lot of unknowns, but that's the status quo as of 2 o'clock today. Probably no more, maybe in the next few days. So with that, since there are no other legislative updates, given that they were out for the election, I will turn it over to MCHB. And today we are joined by Amanda Innes, who is the Senior Advisor and Chief of Staff for Maternal and Child Health Bureau.
Thanks, Amy. Thank you. Thanks. It's really a pleasure to join you all today. Thank you very much. Like Amy said, my name is Amanda Innes. I'm Senior Advisor, Chief of Staff in the Maternal and Child Health Bureau. And I'm just so thankful to join you all today. I have just a few updates from the Bureau to share and look forward to listening to the other guests. We can go to next slide. Great. So many of you are aware that over the past few years, the Department of Health and Human Services has expanded a number of its activities to focus on maternal health. And MCHB's portfolio of maternal health programs is a critical part of that broader initiative. On October 15th, the department announced 2 new challenges to improve maternal health. The first is a $3.3 million Hypertension Innovator Award competition. And the goal of it is to identify programs that care for pregnant or postpartum women with hypertension. The competition is going to be looking for programs that provide effective monitoring and follow-up to improve rates of hypertension control. So we hope that you'll share that with your colleagues. The second is an $800,000 Reducing Disparities in Breastfeeding Innovation Challenge. And the goal of that is to identify programs that increase breastfeeding initiation and continuation rates and decrease disparities among breastfeeding mothers. So the competition is looking for programs that target gaps in breastfeeding education and provide support to breastfeeding mothers. So we encourage you to learn more about these challenges and share them with your partners who might be well positioned to compete. Next slide, please. Great. So I'd now like to share with you a number of opportunities for you and your partners to provide input on MCHB priorities. You're likely aware that MCHB is engaged in a strategic planning process, and thank you to all of you who've provided input to date, either through our email box or through a focus group or listening session. Just recently, we released a request for information, or an RFI, to solicit broad comments from the field to inform our strategic plan. These comments are due by December 18th, and a link is here to the RFI. And we've really appreciated an immense amount of feedback and contributions shared by stakeholders in many listening sessions and town hall conversations. And we're continuing our work with partners to conduct listening sessions and focus groups through well into early 2021. So please check out the RFI, please respond, and please share it with your partners. We really need to hear from you. Next slide. So as shared at the last AMCHP town hall, but of course want to remind you all, and for those of you who may not be aware, MCHB is seeking input on a blueprint for change, guiding principles for advancing the system of services for children and youth with special healthcare needs and families. So we invite you all to review the draft blueprint, the link is here, and provide input on how the work can be operationalized at the community level, the state level, and at federal levels. So this is another great opportunity to weigh in, and we hope that you'll respond and share this RFI with your networks. The deadline is the end of this month, so this one is due sooner. Next slide. Great. And so now another opportunity for you and your stakeholders to provide input. Many of you are likely aware of the Women's Preventive Services Initiative, which is an MCHB funded cooperative agreement with ACOG, the American College of Obstetricians and Gynecologists, to engage a committee of health professional organizations to develop and recommend guidelines for preventive screenings and services for women. And the guidelines ensure that preventive services and screenings are available to women through their insurance plans without cost sharing. So this coming Monday, November 9th, we are slated to release a Federal Register notice to raise awareness and gather public input on a draft clinical recommendation for preventing obesity in midlife women. And more specifically, that will be a recommendation for counseling midlife women aged 40 to 60 years with normal or overweight BMI to maintain weight or limit weight gain to prevent obesity. And counseling may include individualized discussion of healthy eating and physical activity. So you may be aware that most recently, the WIPSI guidelines expanded in 2019 to include screening for anxiety. And we welcome your input on this draft recommendation. Our ACOG partners are going to be collecting input and reviewing comments with the committee and then provide a final recommendation to HRSA. So we hope that you or your partners will share your thoughts. And then next slide. Finally, we just want to highlight that MCHB has a number of funding opportunities open for fiscal year 2021. These will continue to be posted in the coming months, so we hope that you'll stay tuned on grants.gov. But here are a number of open funding opportunities, and we hope that you'll take a look and share these with your partners as well. And that's it. Final slide. Great. So thanks so much for the opportunity to join today. I'd now like to introduce our next speakers. We're so thankful to have you join us today. Kate Guinness, Senior Director of the Child, Youth, and Family Policy and Programs at Mass Health, and Dr. Monica Le, Senior Associate Medical Director at the University of Massachusetts Medical School, Office of Clinical Affairs, and Mass Health Medical Director for the Primary Care Clinician Plan. Thanks so much.
Thanks so much for that introduction. I just really wanted to acknowledge our DPH colleagues and I appreciate the opportunities to speak here today. I see like Karen Downs, Beth Buxton, Katie Stetler, Claudia Catalano. If we can go to the next slide. Going to run through the agenda, and apologies, I think the formatting didn't carry through very well, but I'm going to speak to an overview. Kate and I will be sort of ping-ponging back and forth an overview of how Mass Health approached the COVID emergency, the cross-secretariat and interagency approach that I think many states really had to take. And then 3, we'll talk about one important aspect, which will be telehealth, and understanding that our state, we did have a deficiency in terms of that policy and the rapid expansion, and in response to COVID. And then finally, we'll talk about maternal and child health flexibilities that were exercised among programs. So we focused on 4 main priorities, which the first of which was ensuring access to healthcare for members, which included expediting and streamlining enrollment and eligibility processes. We wanted to make sure testing was provided for all members at no cost, and aligning with CMS guidance, on a continuous basis. We also didn't want to terminate anyone in accordance with the maintenance of effort protections. And we immediately established telehealth guidance to cover all clinically appropriate services, which we'll cover in a few slides later on. And due to a significant decline in immunizations and preventive activities such as lead screening, we saw there was a precipitous decline in lead screening, and there was an increase in lead poisoning during the first surge. So in response, when the healthcare system reopened, we prioritized pediatric visits in order to address these critical preventive medicine concerns. Additionally, hospitals were mandated to reopen all pediatric ICU units for phase 1 of the reopening plan in the state. Secondly, we worked collaboratively across agencies and secretariats. I don't know if your organization is like ours. It's tough not to fall into our silos, but we really were able to reach across and work with our colleagues. As many of you know, in Massachusetts, Mass Health is our combined Medicaid and CHIP agency, and it sits within the Executive Office of Health and Human Services, alongside the Department of Public Health, which is our state Title V agency, and in addition to our departments of mental health, children and families, and others. So like many states, Massachusetts leadership created a COVID command center, so a really single point cross-secretariat strategic decision-making body that helped to coordinate the response for the state. Thirdly, we created flexibilities for providers to really meet the needs of members where they are. For example, immediately on March 12th, we enabled all Mass Health providers to deliver any service via telehealth as medically indicated, and we reimbursed at the same rate as services delivered in person, so both audio and video at parity. And finally, we Our Mass Health Communications team led coordinated efforts across our agency to make sure that members and providers had the most up-to-date information, which included ensuring messaging reaches all Mass Health members, including those with limited internet access. Next slide.
I think this one's me. Hi, I'm Kate. I would just like to emphasize something Monica said, which is our kids and family services we don't have a child agency per se in Massachusetts. Kids sit in many, many agencies. So there was a huge effort to make sure we were working in a really coordinated fashion between Mass Health and lots of other agencies. So to address what we call the SNAP gap, which is kids and families who are eligible for SNAP but didn't have it. There was a really big effort basically to ensure that those who could get signed up for SNAP were getting signed up for SNAP, including having information about SNAP go out with sort of handouts that could be given out to food pantries and other resources, so that to make sure that people who were eligible were getting that. We reached out to our telecom agency, which hadn't worked with them previously, but we reached out to them to ensure that we had all of the information possible. We were very concerned, and I know this was a concern nationally because I've heard about it in other places as well. Internet access and phone access, given our dependence on telehealth, especially in the first wave, but kind of in an ongoing way. We wanted to make sure that we were leveraging every opportunity for people to get access to their care through their internet and their phone. And so we put out a lot of information related to the federal Lifeline program, as well as the flexibilities that internet providers were giving during the first months of the pandemic. Free Wi-Fi hotspots, waiving of late fees, things like that, to make sure that kids and families could get access to the services that we were supporting. We collaborated with our colleagues at the Department of Public Health for several different activities, including a COVID Health Equity Initiative to make sure that we were collecting race, ethnicity, and language data as it related to COVID, testing, diagnosis, and COVID deaths, so that could be tracked. We work closely around early intervention, including increased flexibilities around what was billable, increasing the access via telehealth. And we actually did an expansion to cover early intervention for children who turned 3 between the beginning of the pandemic and about 6 weeks into the beginning of school in Massachusetts, so that those children who were aging out of services would not sort of fall off the EI cliff. We also worked closely with our colleagues around children with special healthcare needs, really thinking about emergency planning if their caregivers were to get sick or self-isolating, and wanting to make plans to ensure that those children were not going to be stuck without a caregiver. And that was a big cross-agency among DPH, Mass Health, our Department of Developmental Services, our child advocate, to really think about solutions. And thus, I'm knocking on wood, we haven't had to implement those thus far, but we have them in our back pocket. And we worked a lot with our provider community for that as well. And lastly, we created cross-secretariat and interagency operational processes so that we were going to be as coordinated as possible, and around issues such as transition age youth, so kids who are aging out of agency care in particular, and wanting to make sure that those kids who sometimes ended up in pretty fragile housing situations were not going to be homeless. And so we've been working to stand up pretty low barrier to entry housing for those kids with supports. And we're using that as a foundation actually for some ongoing work. So we're pretty excited about that as the crisis being the foundation for what we think is going to be an ongoing collaboration among our agencies. Next slide, Monica, it's all you.
As I mentioned previously, for telehealth, we really wanted to make sure that we had expansion, and critical to that was reimbursement for both audio and video telehealth, and reimbursement at parity. There has been variable access to technology, and for instance, smartphones and reliable internet, which would not accommodate that optimal audio video platform. So we do acknowledge that that would be the optimal situation, but the ability for providers to have that platform available, and really the level of comfort for members for that video component, was highly variable. I was just seeing patients, last night, and several of them did not want the video component, even though they did have the technology to support it. So I think meeting members where they are and how they would like to be seen is important. We also expanded telehealth privileges to non-physician providers, permitted out-of-state clinicians to provide care for Mass Health members, and then we permitted the telehealth option for both new and established patients, whereas other payers, it was only for established patients alone. Next slide. Okay.
So we're going to cover the specific maternal and child health flexibilities in these areas that you see in front of you. And I'll start with, if we could, next slide, please. We can start with talking about access. So we've covered telehealth, but we also wanted to make sure that the home and community-based services for people who are in different settings than they might have otherwise been, we wanted to make sure that they could get their services. So we got a waiver expanding into hotels, shelters, and residential schools. Additionally, we heard early on about the challenge. We had previously had a 60-minute requirement on billing for family sessions of ABA for family support. And we heard early on that it was nearly impossible to stay on for 60 minutes on video doing that kind of work with families. So we pretty quickly established a 15-minute support code that we actually will continue moving forward. And lastly, we provided a broad range of financial supports for providers in order to make sure that the system continued to be there. And those were primarily incremental rate increases and supplemental payments for different services. Next slide. So there is, I realize, some Massachusetts jargon on here, but we have a statewide emergency services and mobile crisis intervention team for behavioral health crisis, and we enabled behavioral health, those crisis providers, to not only be doing telehealth into people's homes, but also to be able to do that service from, if someone was in the emergency department and they were needing to respond to the emergency department. And particularly in the beginning, were reticent to be showing up in the emergency department, and the emergency departments didn't necessarily want extra folks coming in. So they were doing that work via telehealth. Additionally, some flexibility around supervision. So the supervision, which ordinarily has to be done on site, this allowed for the supervision to be happening virtually, which was really helpful again. Excuse me. The prior authorization requirements were suspended, so that just in an effort, we really wanted to do anything we could to help the system kind of move along. So where a prior authorization can sometimes delay movement, we suspended those authorization requirements. Our wraparound model, so we have a state wraparound model, and we increased the rates to really compensate for the fact that they pivoted. They were amazing, actually. They pivoted on a dime and went from doing all community-based and home-based work to providing almost everything for several months via telehealth. And so to support their having to really develop a new way of practicing, we increased their rates by 10% for several months. And lastly, relatively recently, we put out an all-provider bulletin that was focused towards pediatrics and family medicine docs, highlighting the importance of behavioral health screening. So we have a behavioral health screening requirement, and we actually generally do pretty well on it. But because kids were not in pediatric offices, and we have heard about the real concern families and kids and anybody who knows them or works with them, we wanted pediatricians and obstetricians to be making sure that they were screening using an evidence-based tool, and whether it was for postpartum depression or the appropriate developmental screen. And one of the things that we were that was highlighted there is the racial and ethnic disparity, and making sure that those who are reading it were thinking about that as an important aspect of the screening that they're doing. So next slide, I think Monica.
Yeah, so I wanted to highlight some of the program changes, specifically in pharmacy and durable medical equipment out of the Office of Long-Term Services. So in the pharmacy program, we wanted to really decrease contact points, and recognizing that it would be essential to decrease risk of exposure, especially for members with chronic disease that would otherwise often come to the pharmacy. We did this by enhancing medication access and adherence, and really pushing options for home delivery of medications. We waived any signature requirements at the pharmacy. We permitted 90-day med refills. And even before COVID, we had coverage of immunizations administered from the pharmacies, but we really doubled down on the policy to enhance patient and provider knowledge of that option, to ensure ease of access for age-appropriate immunizations. In the durable medical equipment space, we added access through both DME and retail pharmacies for critical chronic disease management items. For instance, clinically, we were seeing, that blood pressures were really, a patient might have had high blood pressure, but it was unclear if the shortness of breath that they were experiencing and calling the clinic for, related to their blood pressure at all. So we would have to call EMS to come out to the home if we were worried, to get a set of vitals. And really understanding that those objective tools could better be obtained by having us pay for it through multiple avenues, and really pharmacies access would be an expansion of that. So both blood pressure monitors as well as humidifiers are now available through retail pharmacies. And in terms of infant formulas for enteral feeds, such as those with metabolic diseases or premature babies on hydrolyzed infant formulas, we created some flexibilities to the prior authorization requirements, such that the product could be delivered, before the prior authorization approval was determined. Next slide. And we just wanted to leave a space for questions if folks had it. I'm not sure if you wanted to include that at the very end.
Thanks. Yeah, let's feel free to have people send any questions in the chat. Thanks, Kate, for offering that. Thank you, Monica and Kate, for your presentation. I'm going to move along since we do have a few panelists, but please feel free to put any questions in the chat along the way, and hopefully we'll have some time at the end of the call as well. So moving along, we're going to be joined by Dr. Yanita Riefhaus from the National Center on Birth Defects and Developmental Disabilities, who will give us a brief overview from NCB DDD, and then turn it over to a colleague to present on the recent MMWR. So, Dr. Riefhaus.
Yep. Yep, I'll take it away.
All right.
So, hi everybody, my name is Yunita Refais and I'm the Acting Division Director for the Division for Birth Defects and Infant Disorder. So thank you for inviting me and for having me. I will be joining many of these calls while Dr. Remley is working on the response. So I am pleased to be able to take her spot, and one important role as I take her spot is to remind you all to get your flu shots. I think last time she definitely got her passion across, but it is very important that all of us get the flu shot to keep the country as healthy as we can. So I'm going to share a few updates from our center, and then I'm going to pass it on, like Amy said, to Dr. Kate Woodworth, who is a co-author on two important MMWRs on pregnancy and infant outcomes that came out on Monday. So from the National Center on Birth Defects and Developmental Disabilities, one update is that we have currently open for applications a NOFO for advancing population-based surveillance of birth defects. And the application period for that closes December 8th. And we're looking forward to many competitive applications. So to continue to improve birth defect surveillance. And then from the response, a few updates. First of all, masks. We should all wear them. And CDC has posted an update on how to select, wear, and clean masks. So that's something that is definitely worth checking out to make sure that as we need to wear a mask, we do it properly. And then for the holidays, and with the holidays coming up, CDC is going to issue new content around grief and gratitude. I think these will be hard holidays, one probably with some distance, but also with potential grief. And there's the How Right Now mental health initiative, and they are going to update some content in anticipation of the holidays. And there will be new web, social media, and video content. So keep an eye out for that as well. The planned release for that is November 9th. And then there's also updated considerations on the CDC website, or there will be soon, for winter holidays and small gatherings. A presentation was given on this on October 26th on the partner call, and I'm sure that Wendy is going to share some really helpful web pages in the chat in a minute that really can give you some more information on how to celebrate the holidays safely with your friends and family. And then the other topic that's definitely relevant to all is schools, considerations, guidance, and tools. There's some expected publication of new ones on the CDC website. So keep an eye on those. You know, we have planned dates and we try to make them, but there's going to be new ones on getting schools ready for in-person learning. There's a K-12 school mitigation toolkit, and there's a what to do when a student is showing signs of COVID. So that's an infographic for school nurses, teachers, and parents that should be really helpful. And there's updated K-12 screening students for symptoms of COVID materials as well. And then, as I'm sure you all stay attuned with all the MMWRs coming out, but some recent MMWRs that may be of interest is one that is on COVID-19 mitigation behaviors by age group. And in April and June, the prevalence of self-reported mitigation behaviors, such as mask wearing, hand washing, physical distancing was lowest actually among adults aged 18 to 29 during April to June 2020. So I think that is a really interesting finding and something to be aware of. Another interesting MMWR that's relevant probably to the group is the COVID-19 outbreak at an overnight summer school retreat in Wisconsin that happened in July and August 2020. And this has implications for public health practice because it really describes the need for a multi-component mitigation plan when you have congregate settings such as residential schools or overnight camps. So that's important to be aware of. have. And then the last one I want to mention is a COVID-19 outbreak among a university's men's and women's soccer team in Chicago. There they looked at COVID-19 cases among soccer teams and identified numerous social gatherings as possible transmission events. Something to be aware of in your communities as well. So I'm going to leave it at that. I really thank you for your time. And now I would like to turn it over to Kate Woodworth to present on the 2 MMWRs from earlier this week. Thanks.
Thanks so much, Janita. Yes, I am Kate Woodworth. I'm a pediatrician and a medical officer, typically working in Janita's division at CDC, and currently working on the pregnancy and infant linked outcomes team of the COVID-19 response. Next slide. So I wanted to take this opportunity to share with you results from 2 MMWRs that were published related to COVID-19 and pregnancy earlier this week. The first of these 2 reports compared disease severity among pregnant versus non-pregnant women of reproductive age. This was actually a revised analysis based on national case surveillance data that had been previously published in June. But included double the number of women with COVID-19 that we were able to report on in June. We restricted the analysis to women who had symptoms in order to ensure that reports of ICU admission, invasive ventilation, and other markers of severity were more likely to be related to COVID-19 rather than pregnancy-associated complications. The report also included a higher proportion of women with known pregnancy status reported, so 36% versus in June, only 28% of women of reproductive age had pregnancy status reported. So among the 409,462 women of reproductive age with laboratory confirmed and symptomatic COVID-19, there were 23,434, or 5.7%, were pregnant. After adjusting for age, race, ethnicity, and presence of certain underlying conditions, we looked at chronic lung disease, including asthma, diabetes mellitus, and cardiovascular disease. Pregnant women were 3 times more likely to be admitted to the ICU, 2.9 times more likely to have received invasive ventilation, 2.4 times more likely to have received ECMO or extracorporeal membrane oxygenation, and 70% more likely to have died. And again, this is all compared to women of reproductive age who are not pregnant. Do you want to point out that, again, compared to the June report, I think in that report we were a little bit underpowered to find significance in the difference in death or mortality, but this time we did find a significant difference. Next slide. We also had a second report come out on Monday. This was the first published analysis of data on COVID-19 and birth and infant outcomes collected through our Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet. The map on the left on this slide shows that the 16 jurisdictions that contributed data on pregnant women with confirmed SARS-CoV-2 infection as of October 14th, and were included in this analysis. So 5,252 women were reported. We had pregnancy outcomes known for 84% of these women, or 4,442. Of those known pregnancy outcomes where we had data on trimester of infection, 85% of these infections occurred in the 3rd trimester, 15% in the 2nd, and less than 1% in the 1st trimester. Next slide. So again, of these 4,442 women with SARS-CoV-2 infection and pregnancy and known outcome, 9% had asymptomatic infection, 52% were reported to have symptomatic infection, and we were missing symptom status on 39%. Of the 3,912 live births where we had gestational age reported, we found that 12.9% of infants were born preterm. We were not able to do a statistical comparison to the national estimate, but did want to point out that the national estimate is 10.2% of live births are born preterm in 2019. And so from this suggests that women with COVID-19 during pregnancy might be at increased risk for preterm delivery. I separated out the sort of gestational ages of these births. The majority that we were seeing were late preterm. Unfortunately, we were not able to assess risk factors for preterm birth, like a history of prior preterm birth or indications for preterm birth, to distinguish between those that were induced potentially from maternal disease severity versus those that went into spontaneous preterm labor. I can say we did not find any statistical difference between mothers who were reported to be asymptomatic or reported to be symptomatic. So both of them had higher than the 10.2% national estimate. In addition to this data on preterm birth, I will just add that we also described information on infant testing from 21.3% or 610 infants we had testing information on. And among those, 2.6% of the infants had a positive SARS-CoV-2 test result. And those are primarily born to women with infection around or within 1 week of delivery. And so in summary, the findings from both of these reports for us really underscored the need for continuing monitoring of illness severity and evaluating birth and infant outcomes among pregnant women with COVID-19. Like I said, the majority of these women had third trimester infection, so we definitely still need continued surveillance to understand the impact of earlier infection in pregnancy. But understanding the risks of COVID-19 among pregnant women is important for counseling, for clinical care and treatment, and for evidence-based distribution of resources also. And so on the next slide, I think this has sort of been the immediate result of these reports coming out. See the CDC website language regarding individuals with certain medical conditions that are at increased risk for illness severity with COVID-19 previously had described pregnant women as might be at risk of severe illness, along with other conditions where there was limited or potentially conflicting data. But with these reports, we were able to solidify that language, so it now reads that pregnant women are at increased risk for severe illness for COVID-19. And this distinction helps convey the level of confidence that we have in the evidence, but also allows for clearer communication, which I think we can all recognize is so important with COVID-19. So that language is cleared and up on the website now. Next slide is my final slide. But also just wanted to point out, in addition to the website change regarding risk, we also have websites where we update the number of pregnant women with lab confirmed COVID-19 based on the case surveillance data. And there's one page describing severity of maternal illness, and then we have another page that is dedicated to describing the birth and infant outcomes, again using that SETNet surveillance data. On the slide right now is a screenshot of the maternal disease severity page that just shows, as of last week, we were reporting almost 35,000 pregnant women with lab confirmed COVID-19 and 50 deaths. The website does provide cases by selected demographics like age and race, ethnicity, and also those indicators for severe disease that I was mentioning before, like hospitalization, ICU, and mechanical ventilation. And then the birth and infant outcomes page also describes information about trimester of infection, delivery types, whether these are C-sections or vaginal deliveries, preterm births, and some information about infant testing. And we plan to update that webpage monthly as we get additional surveillance data. So that is the end of the slides that I was going to present on, but I'm happy to take some questions if there are any questions about these two reports.
Thanks, and I apologize because I'm advancing the slide. How do I go back on the slide? Olivia may be able to help do it more easily than I can. Kate, thank you so much. I hope that was, it was a lot of information, so I hope everyone saw. First of all, Wendy showed a number of links in the chat box for some of the other reports that Dr. Weavas had mentioned previously. But if there's any other questions, please feel free to type it in the chat, or we'll hopefully have a few minutes at the end. But we do have one more presenter, so I want to keep moving along. And I'm going to turn it over now to my colleague, Marcia, from our Children and Adolescent Health team, who's going to introduce our guest speaker.
Thanks, Amy. Hello, everyone. My name is Marcia Stepensky. I'm a program analyst on the Children and Youth with Special Healthcare Needs team. And I am very, very excited to be introducing Opal Bisa to you all. I'm not going to spend too much time introducing her because I want her to chat with you all, but she is a young woman from Montana, and she is really concerned about the alarming statistics related to mental health and suicide risk in her state, and will be sharing her perspective of how public health leaders can better support young people, both with and without disabilities, during challenging times like right now. So Opal, thank you so much for joining us. I'm passing it to you.
Thank you, Marsha, for that great introduction. Hi, everybody. I'm Opal. You can all see me, right?
We
and
can.
hear me?
Yes,
Okay.
we can.
Hey, that's good. I just wanted to check because I wasn't sure that it turned on. It was being difficult. Anyway, my name is Opal Bisa, and I live up here in Kalispell, up here in the corner of Montana over here. But my state has alarmingly large mental health problem. According to the Department of Public Health and Human Services, we have been in the top 5 suicide rates nationally for the past 30 years. We have held a spot in the top 5. And that is really alarming. Especially among teens, our suicide rate has ranked 3 times the national average between 2012 and 2016. That is alarming. And so basically last year, my high school, Glacier, had 2 suicides, one in January and one a couple months later in March. And I think I figured out what the problem is and what school staff and people, policy makers, legislators, what everybody needs to do to fix that. I've noticed in my school that counselors seem like they're there more to fix your schedules than they are to have a conversation with you on mental health. I feel like mental health takes the backseat when it should be schedules that are taking the backseat. And so I feel like if schools emphasize the fact that there are people there to help you with your mental health, that would get a lot better. And also I feel like, and I don't know if what policymakers can really do to fix this part, but I've also noticed that teenagers are pretty absorbed in themselves and don't tend to notice when a friend is lonely or not acting like themselves. And so also particularly students with disabilities, like I think students with disabilities, particularly those in self-contained classrooms, really face an even greater deficit because they're not given very many chances to interact with their typically developing peers, and that is unsettling that they could make excellent friends and yet they're not given the opportunities to really go out and interact. And I think education on the part of the typically developing student is a very large part of it too. like the typically developing student doesn't always know how to talk to the student with a disability, how to interact with them, what is politically correct to say, what is not. And so at the moment I am working on a set of slides to try to bridge that gap and offer some education for students. And thankfully Marsha and Paige are being so gracious as to help me with that. And so hopefully as I get that done, we'll see a decrease, but I don't want to just fix this in my school. This needs to be fixed for all sorts of people, students, teachers, people with disabilities, people without disabilities. Mental health is everyone's issue. So everybody really needs to do what they can to, especially in time of COVID, when so many of us with disabilities and health issues are isolated. Everybody needs to do what they can to make sure that the people that they love know that they are loved, that they are valued, and that they are needed in this world, because every person in the world is needed in the world for something. And just take care of the people around you, please, everybody.
Opal, thank you so much. I wanted to answer one of the questions that you posed about what policymakers could possibly do. And I think certainly one thing, there is a role for sure, and that is, you know, when you're talking about the challenges with resources available in schools, certainly, you know, passing the state budget and providing funding for educational and health supports that are needed in the school setting, I think that is absolutely an area, and this is just off the top of my head, like where I think they could really benefit from hearing the voices of students who, like you, have that firsthand experience, because I think most policymakers and even the people who tend to do most of the advocacy, they're not as connected, they're not on the front lines, they're not in touch with what students who are experiencing the real pressures and challenges in school. So thank you so much for sharing your perspective. And it's really valuable for you to share your story and your firsthand experiences. And thank you for making yourself available to share with us. We only have a few minutes left, so I want to open it up for questions. All of our panelists, I think, are available for questions. Opal, I hope you can see the chat. There's a lot of kudos to you, and thank you for your insight and sharing your wisdom with us today.
Yes, I see that. Thank you all for giving me the opportunity to do that. And for the and Marsha and Paige and I will be doing we don't know when yet, but I think we're doing some sort of webinar to present the slides, but I'll drop that link in the chat for those of you that would like to see the slides early, see them right now.
Awesome.
I'll just get
Thank
that
you.
and drop it in the chat.
Great. I'll give folks a moment if you want to either unmute yourself to ask a question or to type that in the chat. I'll also share in the meantime a couple announcements. A reminder that ACA open enrollment season is underway right now, and AMCHP does have some resources available. I will ask one of my colleagues to put that in the chat as well. Thank you, Jess Cohen. Also a reminder that the AMCHP 2021 conference is scheduled for May of 2021. Obviously, we'll be, evaluating as time goes on about the feasibility of holding it in person, although regardless, there will be some sort of virtual option, whether it's hybrid or fully. But just so you are aware, abstract proposals are due by Friday, December 4th. This is an extension from the original date, so you have until Friday, December 4th to get those in. Thanks, Jess. Our next call is on November 19th. Be sure to register for that. And we have 5 more minutes left. If anyone has any questions, a couple of more lovely words for Opal. I agree. I wish I was as smart as you when I was in school. I just want to make sure I didn't miss any questions that might have been typed in the chat. Any other questions? All right. Well, thank you again to all of our wonderful panelists. And Opal, did you already share the link to your?
I am working on. I have it. Sorry, it takes me a while to type. So sure. I am getting it for you right now.
No problem. I'll leave it open so that you have a moment to put that into the chat. Also, we can make sure that we circulate it otherwise, because it sounds like there is another webinar planned from our child and adolescent health team, who are awesome as always. So I'll just leave this up for a moment if anyone else has anything they want to share. We'll meet again in 2 weeks, possibly with more information about the outcome of the elections, as well as what to expect in the next few weeks in Congress, as I think they'll be coming back that same week. There is usually orientation then, which is interesting. If there are races that haven't been called yet, they typically, I know at least in the House, they typically invite both candidates back for orientation so that I guess both of them are oriented as well as they need to be when they return. Oh, great. Opal just posted the link. Thank you so much. So we look forward to seeing you, and please fill out the survey at the end of the call as well. Have a great afternoon, everyone.